Well, a warm welcome to today's talk. It's Saturday the 7th of August. Now, today is mostly a good news video because the amount of long COVID that children are getting seems to be quite small. And we only learnt this yesterday, that the information has just come out. So we're going to go on to that for most of this video. But before we do, I just want to report a couple of interesting things. The first one is that the Delta variant has returned to China big time. Now, when I say big time, I mean widely distributed. The actual number of cases is relatively low compared to the UK and the States. But it's the Delta variant and it's very much a risk. So, for example, the city of Wuhan, which you might remember from last year, 11 million people are being surge tested in the city of Wuhan. 11 million people are being tested. Quite incredible capacity for doing this the Chinese have got. As the Chinese vaccination program rolls out really quite quickly now, I think they're up to about 1.6 billion doses of vaccine. But the Delta variant is posing a threat, and exactly how much immunity the Chinese vaccines are going to give against the Delta variant may not be as good as the messenger RNA vaccines. In fact, I'm pretty sure it's not. So that was just brief news from Wuhan, which I thought was interesting. The whole thing seems to have gone round the world in a circle back to Wuhan now. Dave in Mississippi. Now, this is building on the material we were talking about yesterday for the concerns for the United States, so particularly Texas and Florida. But Dave, living in Mississippi, is also worried about Mississippi. I'm going to read the main points of his email out. Things looking horrible in Mississippi right now. Record numbers of cases every day, and people are going about their lives as if nothing is happening. Now, Dave actually sent me a picture that I can't actually show you because it's got children in it. But it was just a school event, mums and kids there, just acting as if it looked like a perfectly normal thing. No masks in sight, no social distancing. The doors were closed. So people are just living their lives like nothing is happening. It's this strange kind of denial. I can't quite work it out. We are short 2,000 nurses throughout the state. And from this same time last year, because they have left to find other jobs elsewhere, according to the Mississippi Department of Health. So 2,000 nurses short. State leadership is mum on anything. So they're not saying anything. State leadership is mum on anything. And now our governor has not been seen in weeks, according to Dave. The largest hospital in the state is holding press conferences almost daily, trying to convince people to get vaccinated and stay home. Currently, we have 14 ICU beds available in the state, but that won't hold for long. And also no staff to actually work the beds. All of this happening, and you still have schools opening, no mandatory masking, and having events like the one in the picture that we talked about. That event has caused over 100 quarantines so far, but no real way of knowing how many infections happened because schools are not required to report. I am fearful that our medical system here will fully collapse. And he includes some references. So, Dave, thank you for that. When we are concerned about these southern states, especially where vaccination rates have been low. So that was straight from Dave's email. So thank you for that, Dave. Very useful information. If concerning, but certainly reinforcing the issues that we raised here yesterday, and indeed we've been raising for a couple of months now since we realised that the Delta variant actually was in the United States at a level of about 1%. And we did warn that this was the likely outcome. And of course now it's more than 90% is the Delta variant in the States. Now, the debate about vaccinating children goes on. Two main risks in children, the multisystem inflammatory syndrome and long COVID. But this report from the COVID symptom tracker Zoe app, Tim Spector Group, King's College, London, shows that the actual amount of long COVID in children is reassuringly low. So I want to spend a bit of time looking at this because it is fairly good news. And it really does somewhat undermine the argument for vaccinating children, as we'll see, especially for vaccinating children under the age of 11. But let's look at that and you can make your own mind up. I'm not going to force you to one opinion or another. Illness duration and symptom profile in symptomatic UK school-aged children tested for SARS coronavirus 2, published in the Lancet. So it's peer reviewed. It's not in the paper format yet, but it's all there, done. PDF is available there, and there's a popular news article about it as well. Now, the background here. Infection is usually asymptomatic or causes mild illness of short duration in children, thankfully. Didn't have to be this way. We're just fortunate that this virus does not particularly like attacking children, or it doesn't cause major symptomatic disease in children. Other viruses could have done, other viruses in the future could do. We've been somewhat fortunate by that, but it is the case. Persistent illness has been reported. The question is how much. So this study is to determine illness duration and characteristics in symptomatic UK school-aged children. So that's what this is about, part of the COVID symptom study. Now, the methods is a prospective, looking forward, cohort study. So prospective is good, cohort's good because we get a lot of people. Children aged 5 to 17. So this is the whole range of that age group, 5 all the way through to 17. Now, under that age, they were all reported by a proxy adult, usually parents, but quite often children in school as well, who, with parents' permission, teachers monitored this and were able to report quite large amounts of data to the COVID symptom tracker people. So well done those teachers, and of course, well done to all the parents that gave this information about their children. Illness duration and symptom prevalence for children testing positive was looked at, so children testing positive. But one of the things that they're doing, typical of these studies, they're very, very thorough. Data from symptomatic children testing negative for SARS coronavirus 2 was also matched 1-for-1 with age, gender. Week of testing also assessed. So if the children tested negative for COVID-19, presumably it means they had some other viral illness, given that the PCR tests would very likely have picked this up. So interesting that they've had a sort of a comparison group there. So I thought that was quite a nice touch, really, that they did. Now, findings in children aged 5 to 17. So this is the whole group now. Now, March 24th, 2020, all the way through to February 2021. So that's really 12 months, isn't it? So that was a good amount of data they collected. And they collected data from 258,000 children, 790. So a good number, very good number. Valid test results of those, they had 75,529 had a valid test result. So of that number of children reporting, that's the number they had a valid test result for, so that's what they could use. Now, of that 75,000, positive test results were 1,734 children testing positive. Now, again, these are still very good sample sizes, and you can get highly significant, good statistical data from these kind of numbers. 588 younger and 1,446 older children. And younger children, on that definition, are 5 to 11, and older children are 12 to 17. So not only did they have the test results, they also got information for the illness duration. So they had information on the illness duration and the symptoms, and they had information on the positivity of the testing. So they had the information that was required to be able to follow this group up really quite accurately. Now, before looking at long COVID, they looked at other symptoms. And what they found is in children, this is 5 to 17, headache was the most common. So that's 1,734 children. 62% had headache. Fatigue, 55% had undue fatigue. 1,700 of the 1,734. So headache and fatigue by far the most common symptoms in this group of children. There's 1,734 for which they had follow-up data and for which they had positive tests. Now, median duration of illness in children. So what they found here, children testing positive, their illnesses lasted for a median of 6 days. Children testing negative, it was shorter at 3 days. So median illness duration in children, basically for COVID, is 6 days. 3 to 12 was common, but 6 days was the median. Illness duration associated with age. Now, I'll just come back to that in a minute. What they did find, older children age 12 to 17, it was typically median illness duration was 7 days. Younger children, it was 5 days. So this was correlated with age. Now, what this does, this is the R. This is a correlation statistic, and what this says, what this is telling us, is that there was a positive correlation between longer symptoms and increasing age, and they were very sure about that. Only one chance in 10,000 that result arose by chance. So now the correlation is not a strong one. If there'd been no correlation at all, the R value would have been 0. If it had been a perfect correlation, positive correlation, the R value would have been a +1. A negative correlation, it would have been -1. So there's definitely a correlation here. They're statistically sure about that. And that is the trend, that basically older children get symptom duration for longer before we actually go on to talk about long COVID. So that's what we would expect in younger children. 5 days. For those, of course, this is for those that were symptomatic. Of these, a proportion will be asymptomatic, and of course, of these, a proportion will be asymptomatic. But it's rather harder to tell that because this is the COVID symptom study app, and the people that were symptomatic went for testing. So we can't go beyond what this data is telling us. So interesting information there about COVID in children generally. Now, illness duration of at least 28 days. So out of this group of 1,734 children, there were 77, 4.4% of the children. Overall, it was 28 days. So that was overall, that was for all the children 5 to 17. Now here, these are divided into two groups. So the older children, the 11 to 17s, there was 59 of the 1,146 older children, and there was 18 of the 588 younger children, meaning that there's 5.1% of the older children had symptoms for at least 28 days, and only 3.1% of the younger children had symptoms for at least 28 days. So again, we see older children are more likely than younger children to have longer term symptoms of at least 28 days. So again, that was, and the difference, what they actually did was they took that number there, taking those as one group there, so the older children, and they compared that with a younger group. And when they compared that group with that group, they found out that this difference in illness duration lasting for at least 28 days was significant. The p-value was 0.06. In other words, they were over 95%, in fact 96% confident that that was a genuine result. So reaching significance. So that was another thing they found out. Now, after 28 days, the median symptoms in the whole group of children, the 5 to 17, after 28 days, the median for those children that did have symptoms for up to 28 days, they were down to 2 symptoms. First week of the illness, the children that are going to go on to get symptoms for 28 days, they had 6 symptoms. So we see the number of symptoms also going down rapidly through that first 28 days. And of course, it was the minority of children, only 4.4% of the children overall, 77 of the 1,734 children, that's 4.4%, that got symptoms for those 28 days. And even the ones that did, after the end of 28 days, the median was only 2 symptoms left. So all looking more positive than we'd hope for children. We had thought, well, basically we didn't know, were children getting long COVID as commonly as adults or not? It was unclear until this data came out. And this really is very reassuring that they're suffering from long COVID at a lower rate than adults, which is great. And of course, I'm not going to go over the adult stuff now because we've looked at that in the past. So good news so far. Commonest symptom in the first 4 weeks of illness. This is for those that did have symptoms for 4 weeks, the 28 days. In those that did, fatigue was the most common, 84%. Headache was the second most common, 77.9%. And anosmia, the loss of smell, 77.9%. Now, there is a slight proviso here, of course, because a lot of this data was collected during the wild type variant when that was prevalent in the early part of 2020, and when the alpha variant was prevalent and only just going into the delta period. So it's there is a provisos there, but that does seem to be even now what's happening: fatigue, headache, anosmia in children that lasts for 28 days or more. Now, symptoms that lasted for at least 56 days, that was 25 of 1,379 children. Now, I know that's less than the 1,734 we were looking at before, but these are the number of children that carried on reporting symptoms for this longer period. So, or had their symptoms reported for them for 56 days. There was 1,379 children, and 25 of those were still symptomatic at 56 days. That's 1.8%, albeit with typically fewer symptoms. So it's not saying children can't get it. In fact, they're going to interpret this now. So let's just do that briefly, then I think we're done for today. So the interpretation there, COVID-19 in children is usually of short duration with low symptom burden, which is great. Some children with COVID-19 experience prolonged illness duration, but relatively small amounts. Symptom burden did not increase with time. It went down with time. That's quite important. So they weren't accumulating symptoms as they went along. They were getting rid of symptoms. And of course, the vast majority recovered by 56 days. So the vast majority, so 1.8%, so that's 98.2%. Is that right? 98.2%. 98.2% were fully recovered in that time period. So not saying it can't happen, but less frequently than we had. Less frequent than we had feared, and a lot of people had feared. Now, more information to come on how many of those children over 56 days were severely or long-term affected, but it's looking like it's fairly small. So basically, this is looking fairly encouraging and doesn't really give strong support to vaccinating children under the age of 11. But of course, that has to be taken into account by the governing bodies, taking into account other features as well. So that's it. That's to date. Now, I just think I'd do one more thing. Yesterday, I said I think it was about 16.4% of people tested of the 92% roughly that are antibody positive had the natural infection. And I said at the time, I'm not sure how they tell the difference. Well, someone emailed me, and of course, it's completely obvious, completely obvious when you're told. So the difference is that, of course, we have the virus here. That's the virus with its spikes, as we know, like that, with a spike protein on the end. Now, the vaccines that we have been given, whether it's the mRNA vaccines or the adenovirus vector vaccines, they're just making S spike protein. So the vaccine's only given the spike protein or producing the spike protein. Therefore, people only produce S spike protein antibodies. So if they have S antibodies, that means they could have had the vaccine or the natural infection, because the natural virus and the vaccine both have spike proteins. But then, of course, there's another protein associated with the membrane called the M protein, and that protein was not part of the vaccines we gave in the UK. So if the M protein was present, that indicates a natural infection. And of course, associated with the RNA inside the virus itself, there's another type of protein called the nucleocapsid. Nucleocapsid protein, or the N protein, and of course that would produce N antibodies. So people who had natural infection would have M antibodies. They would have so in other words, the body would have raised antibodies against the M antigen. The nucleocapsid, they would have the N antibodies, and they would have the S antibodies, whereas people that have been vaccinated would only have the S antibodies. So pretty obvious that people that have been vaccinated would not have the M and they would not have the N, whereas natural infections would. So, of course, I can't remember the name of the person that sent that in, but thank you very much. It's obvious. Now, of course, this probably wouldn't work with the Chinese vaccine because that's giving whole dead virus. So presumably to these other vaccines, you make antibodies to all of the components of the antigen that you're injected with, which would include, because it's the dead virus, the spike protein, the membrane protein, and the nucleocapsid protein would all generate their requisite antibodies. So they would have spike protein antibodies, membrane protein antibodies, and nucleocapsid protein antibodies. So there we go. Hope that was useful and basically reassuring about children. The slight thing in my mind, this odd, the small number of children that still have it, the 1.8%, how many of those are going to have it for longer periods of time, and how many are going to be severe? So that information's not there. So that would be my kind of proviso, because if it does turn out, I don't think it's going to, but if it did turn out that 1.8% of children are going to be severely symptomatic for a few years, then that would be a big concern, of course. But nothing to indicate that is going to be the case at the moment. So at the moment, so far so good, looking optimistic. But of course, more data will be collected as time goes on. So that is us for today. Thank you very much for watching.